Testing, testing, testing. Erica, can you hear me?
Yeah.
Very good. Okay, Erica, can you tell me if the slides move when I do this?
Yes.
They do. Okay, very good. Evening, everyone. We have some people on Zoom. Some folks a little under the weather. That's okay. You can get on Zoom. That's just fine. Bless you. We're going to finish the discussion of osteoporosis medications. Then we will look at drugs for rheumatoid arthritis. Then the unit after that is a respiratory unit. So the two units there are asthma and allergic rhinitis, allergies essentially. Many of the medications are going to overlap in that regard. So I don't know if you're paying attention to the news yet, but the Russians have still not taken Kyiv, and they've also not taken the second largest city in Ukraine, which is west of Kyiv and a little bit south. And you've got to give those Ukrainians a lot of credit. So we will continue to pray for them and hope that that Russia just gives up and goes away. Let's pray. Father, we continue to lift up our Ukrainian brothers and sisters. We thank you for their courage. We thank you for the leadership they have around them. We thank you that they strongly believe in the country they are defending. We pray for them that you'd lift their spirits, that you would give them success, most of all, Lord, that the hostilities would end. Thank you for every person here. For those feeling under the weather, we pray for a healing hand upon them. Now, Lord, we pray for a learning hand upon us this evening. In Jesus' name, amen. All right, we left last time we talked about nutrition, importance of calcium, load-bearing exercise, vitamin D. We just mentioned strontium ranolate, which is not available in this country, but seems to work. In clinical trials, at least, it seems to work. Why it's not available in this country, don't ask me, ask the FDA. So this leads us now to the recombinant parathyroid hormone mimics. These are peptides. They're synthetic peptides, so they have to be injected. You can't take them orally. So native parathyroid hormone is a small protein, about 84 amino acids long. The synthetic versions are quite shorter. They're just the amino terminus of the protein. That's fine. That's the piece that binds to the parathyroid hormone receptor. Now, parathyroid hormone, let me remind you, low levels of parathyroid hormone activate osteoblasts. High levels of parathyroid hormone activate osteoclasts. When do you make high levels of parathyroid hormone? Sorry? I don't understand your answer. No. Low levels of parathyroid hormone stimulate osteoblasts, the cells that build bone. High levels of parathyroid hormone stimulate osteoclasts, the cells that destroy bone. When in your body are you going to make high levels of parathyroid hormone? What stimulates parathyroid hormone to be released by the parathyroid gland? What's the trigger? Low calcium, exactly. There are receptors on the surface of parathyroid cells called calcium sensing receptors. When those cells are bound by calcium, they are inhibited. When calcium is not bound to those cells, the receptors are activated. They stimulate the exocytosis of vesicles laden with parathyroid hormone that then are secreted into the bloodstream. Parathyroid hormone at high levels will activate osteoclasts. At low levels, that low level of release that you usually get from the parathyroid, they stimulate osteoblasts, so they stimulate bone deposition. So by taking parathyroid hormone mimics, you stimulate osteoblasts. So they stimulate the osteoblast to make rankle. Rankle is that molecule that's released by osteoblasts that stimulates osteoclast precursors to fuse and become multicellular osteoclasts. They'll secrete an array of proteases that degrade the collagen and then hydrochloric acid to dissolve the bone matrix. That releases calcium. That raises calcium levels. Calcium levels will then feedback inhibit and prevent the release of further parathyroid hormone. So the intermittent activity will stimulate the osteoblast activity. That's what you're trying to mimic by giving these parathyroid mimics. You're trying to mimic this intermittent parathyroid release that stimulates bone building. So you're going to inject this material daily. You inject it subcutaneously. Its absorption into the bloodstream is gradual. So you get this gradual level of parathyroid hormone, that low gradual level of parathyroid hormone stimulates osteoblast activity. Okay, is that clear so far how it works? So your job as the nurse, you're going to have to teach the patient how to inject subcutaneously. So they have to pinch the skin, show them what the subcu layer is, that they have to pinch the skin and get the needle essentially underneath the dermis and epidermis. If they don't, the absorption will be terrible. So the side effects include nausea, relatively common. 15% or so patients get nausea. Joint aches, that's quite common. That's about 20-25% of patients will get joint aches. The joints that ache tend to be the bigger joints. Pain, just generalized pain. Cramping in the legs, probably due to calcium level fluctuations. And then usually there are some injection site reactions. If you alternate injection sites like you're supposed to, that becomes less of an issue. Also, as the patient gets better at injecting, that tends to not be quite so much of an issue as well. A serious side effect is orthostatic hypotension. Who can tell me what that is? Orthostatic hypotension. Right. You change position, you go from lying down to standing or something like that, and the world starts to spin, and you may fall down, you may need to sit down again. You might even experience so-called syncope. Syncope, of course, is, there you go, fainting. Good job. Usually about 4 hours after you inject this stuff, your heart rate will tend to go up. That will tend to go away though. Just warn the patient about that. Common, it's not anything to be worried about. You need to worry if the patient has low energy, low muscle weakness, combined with nausea, vomiting, constipation. That will suggest they have hypercalcemia, too much calcium in the blood. That's a side effect you want to really be leery of. So this simply shows you essentially how it works. It stimulates the osteoblasts and so on and so forth. We'll take a look at these others and how they work and what have you. Remember, the osteoblasts will make rankle. Now, again, I have very dumb ways of remembering things. For rankle, just think wrinkled, wrinkled. So think of the osteoblasts, they have wrinkled shirts on. They make wrinkled, which is actually rankled. But rankles, wrinkled, you could remember that probably. They make rankle that binds to rank on the surface of the osteoclast precursors. Those cells will fuse. They become multicellular osteoclasts and they will etch the bone. They will degrade the bone. So here's some data from clinical trials. This is more or less to just convince you that this stuff works. So at 19 months, there was a 65% relative risk reduction, almost 10% absolute risk reduction of new vertebral fractures over placebo. And then new non-vertebral fractures, relative risk reduction, 53% absolute risk reduction, 3% over placebo. That's significant. And then bone density, you can see, goes up substantially relative to placebo after 18 months. So you get a essentially 12% increase in bone density. That's nothing to sneeze at. There's a black box warning on these drugs in laboratory experiments with laboratory animals, particularly rodents. The rodents developed osteosarcoma. Osteosarcoma has been reported in people who've taken these drugs, but very rarely. So it does seem to be a risk, but it's a low risk. Okay, questions about teriparatide? So a newer parathyroid mimic is this one, abaloparatide, Timlis. So the FDA approved this for treatment of women with osteoporosis for up to 2 years, and it's meant to be used in women who are at high risk for osteoporotic fractures. Osteoporotic fractures occur where? There you go, Caitlin, let's say it. Wrist, good. Where are the other two? Yeah, hip and vertebral column, very good. Good, all three. Good job, Caitlin. Pat yourself on the back. Okay, that's enough. This one also, it needs to be injected. So you get injection site reactions, a lot of the same side effects that you see with teriparatide. You get the increased heart rate a few hours after you inject it. There's not as high an incidence of hypercalcemia with this drug, it seems, as with teriparatide. You also get hyperuricemia, increased uric acid concentration. So what does that tell you about using this drug in someone with gout? Probably not, or use it with remarkable caution. There's also a box warning for osteosarcoma. There's not a lot of data clinically on how much osteosarcoma this drug causes. The guess is that it probably has about the same risk as teriparatide. These come in injector pens, so the patient will inject themselves at home. They don't have to go into the doctor's office to get injected unless they really hate needles and they can't do that, in which case they may actually hire a nurse, you, to come in and give them injections, which is a nice way for you all to earn a little extra money on the side. Because some people just can't bring themselves to inject themselves. It happens. So the ATI site talked about calcitonin. The FDA has withdrawn their support of calcitonin for use in osteoporosis. And I called the pharmacy before class tonight because last year I said, do you guys still supply this? He said, yeah, but we never use it. So I called Andy again and I said, do you guys still have calcitonin? He said, no, we pitched it, it expired. So this came in two forms, human calcitonin and salmon calcitonin. The salmon calcitonin was a lot cheaper. There's just not a lot of evidence that this drug works that well. That's why it's been pulled. It came in an intranasal form. That intranasal form is really well tolerated. But because it's not really shown that it can work, it can do the job, most people who deal, it's usually endocrinologists now who do a lot of the osteoporosis work, they won't prescribe it. So this is a drug that will increase your it'll decrease osteoclast activity in the bone. So it increases bone deposition, at least theoretically. But the panel in 2013 said, no, lack of benefit. So I doubt you'll see this drug very much. So I'm really not going to spend much more time on it. Now, this newer drug you are going to see, because this drug is really earning its stripes in post-marketing data, and that's this drug, denosumab, or denosumab, depending upon where you put the accent. So this is a monoclonal antibody. It inhibits wrinkle. What does wrinkle do? Wrinkle there you go. Yeah, stimulates the osteoclast precursors to fuse and become osteoclasts. So if you inhibit wrinkle, you're going to get osteoclasts? No. You're going to get any bone destruction? No. So that's what this drug does. It's a monoclonal antibody. It binds and inhibits wrinkle. So it's given by injection. So one of these for osteoporosis, Prolia, is given once every 6 months. Exgiva is used for people with cancers that have metastasized to the bone, and that's given once a month. Also SC. Increases bone density, decreases fractures. Most common side effects are muscle pain and back pain. Muscle pain and back pain. Now, if you x-ray those people or use an MRI on these people on their back, nothing seems to be wrong with their back. It just hurts. So that's one, just warn people to expect this. Some people get pain in their arms or legs or both. Some people just, their muscles get really sore and stiff, particularly in the morning. Cholesterol levels can climb, usually a little bit, and some people substantially. There's increased risk of cystitis and also increased risk of upper respiratory infections. There have been reports of osteonecrosis of the jaw. That's rare. Does happen, but it's rare. Are you going to screen somebody for that? Osteonecrosis of the jaw, what does that feel like on the jaw? The bone is soft. So you're going to ask if they have any loose teeth. Have you been to the dentist lately? Lost any teeth? Anything like that? So just give the jaw good press, and if there's something soft, you tell the provider ASAP. That's how you're going to screen for osteonecrosis of the jaw. All right, so these are the reductions of fracture risk versus placebo. So your 1, 2, and 3, you can see that the reduction is substantial. Substantial. If we look at hip non-vertebral fractures, we see again significant reduction in fractures, and look at the bone density increases. That's hard to argue with. And especially when you look at placebo. Placebo is looking pretty pathetic. All right, questions on those drugs? Those drugs are non-hormonal. Like the bisphosphonates, they're non-hormonal. Now we're going to talk about the hormonal ones. So raloxifene is a selective estrogen receptor modulator. Selective estrogen receptor modulator, a SERM, a SERM. So this one is it's a partial agonist of estrogen receptors in bone. There's different estrogen receptors and they show tissue-specific expression. This is due to different genes and alternative splicing of those genes. So these different protein products have different biological effects and they bind different drugs. So they're going to activate estrogen in the bone. By activating estrogen in the bone, you inhibit osteoclast activity and tend to promote osteoblast activity. However, they antagonize different sets of estrogen receptors found in the mammary gland tissue. So these are ideal drugs for women who might be at increased risk for breast cancer, but are experiencing osteoporosis. Completely ideal drugs for that. So raloxifene is a drug that in certain populations gets used a good deal. Trying to find the price here. Generic raloxifene, you take it once a day. 30-day supply is $60. So it's not terribly expensive. Denosumab, it's the cost of one pen. Now this is for 6 months. Is $1,278. It's a newer drug. It's an antibody. It's more expensive. Side effects of this drug are estrogen-like side effects: hot flashes, leg pain. In some women, it can be substantial leg pain. Also, with an estrogen mimic of some sort, you're going to have increased risk of venous thrombosis, VTE, venous thromboembolism. So your risk goes up. Oral drug, though, very convenient. You don't have to inject it. This particular drug is rather new. So Dwavi is a fixed dose combination of this selective estrogen receptor modulator, vasodoxifene, and conjugated estrogens. That's supposed to be conjugated. That's S is supposed to be a D. I'm sorry about that. This is FDA approved for prevention of osteoporosis and the treatment of the symptoms of menopause in women who have an intact uterus. So the vasodoxifene inhibits the stimulating effects of estrogen in the endometrium. Therefore, it reduces the risk of uterine cancer. Like raloxifene, it inhibits the stimulating effect of estrogen in the breast as well. There is no increased risk of breast, ovarian, or endometrial cancer, but there is an increased thromboembolism, venous thromboembolism risk. That's probably the biggest one. The other side effects are pretty minor. Minor that in the number of people who get them doesn't seem to be high. So the clinical trials showed things like muscle spasms, nausea, dyspepsia or upset stomach, abdominal, neck, and oropharyngeal pain. Not very high percentage of people reported them. So they were reported, but it was low percentage. It's usually fairly well tolerated combination. So those are the two hormonal-based drugs. This combination, Duavi, and this other one, Relaxine. Questions about those? That is, by the way, is also oral, taken once a day. All right, no questions? This drug is really new. This drug came out last year. So the amount of data on it is not great. You're probably going to see this drug more and more. So in explaining how this drug works, let me refer you to this monstrosity, this abomination over here called the drawing. So when the osteoblasts make bone, they work themselves out of a job. They get trapped within the bone. And then they extend these long cytoplasmic processes and they make contact with another former osteoblast. These cells are now called osteocytes. Now they secrete a molecule that's essentially telling each other everything is fine. We don't need to make new bone because the bone here is good. And that particular molecule is called sclerostin. So sclerostin is a molecule that inhibits bone deposition. So this new drug here, romosozumab, it's an anti-sclerostin monoclonal antibody. And it induces osteoblast activity essentially directly. So it decreases bone resorption, increases bone density, and the bone forming effects will decline after 1 year of use. So these are your osteocytes. While they're touching, they're essentially making sclerostin. Sclerostin, as you can see, is going to inhibit osteoblast activity and inhibit the differentiation of mesenchymal stem cells in the bone marrow cavity from differentiating into osteoblasts. By inhibiting sclerostin, you now recruit more mesenchymal stem cells to become osteoblasts, and you free the osteoblasts to make more bone. That increases bone density and increases bone strength. Okay, see how that works? Kind of like, think of it like these osteocytes, they pass notes to each other. And essentially this is the terrible teacher who goes through and confiscates all the notes. Now nobody can say anything, so they start causing lots of trouble, like making more bone. Most common side effects from the clinical trials were joint pain and headache. Infrequently, you get adverse cardiovascular events, heart attacks, angina, things like that. You get those more frequently than you get with alendronate. You can see the percentages there. So it's the manufacturer has said that people who've had a myocardial infarction or a stroke shouldn't take this medicine. That's a contraindication for the drug. Out of 4,093 participants in the main clinical trial, there were 3 cases of osteonecrosis. So is osteonecrosis a potential side effect? Yeah. Does it occur very often? No. So it's a rare potential severe side effect of this medication. So what's in the works? There's a company that's testing a transdermal teriparatide. That's quite a trick. To get a peptide to go across the skin like that, they've encapsulated it in a little microcapsule that the pad releases into the skin. It diffuses into the skin, into the sub-Q where it gets absorbed. You gotta admit that's cool. So that's on the horizon. And then another anti-sclerostin monoclonal antibody called losuzumab. So that is a relative to rosuzumab. It completed phase 2 trials successfully. The phase 3 trials I just checked this afternoon are about halfway done. So that's a drug you might see getting approved before long. Any questions about osteoporosis medicine? First line is going to be the bisphosphonates. Big thing about bisphosphonates is the way you take them. You must teach patients about how to take them. They must remain upright for at least half an hour to an hour after taking them. They must take them with just water, plenty of water. And they must take them on an empty stomach when they first get up in the morning. That will diminish the esophagitis, the upset stomach, the esophageal ulcers, and so on and so forth. Okay. No questions? All right, then. Okay. Do you want to take our break early and then start this? Or do you want to just plow through until 1:45? What do you want to do? I'm sensing tremendous indifference. Cassidy says plow through. Okay. Oh, you want it? No, that means now. I thought you were pointing at your computer saying, let's get with this. Okay, let's take our 5-minute break now, and then we'll start this because I thought the ATI did a really good job on methotrexate. So methotrexate, I'm just going to run through it, but the other drugs we'll talk about as well. Okay, let's take 5 and then come back. Yeah, you are. Someone asked me, I couldn't remember who it was. And then both you and McKenna are both blonde. Yeah. Really? Yeah. No, that's my wife. Your hair cycle stops when you're pregnant because of the estrogen, and then your hair cycle comes back with a vengeance once you give birth. And so you think you're losing your hair, but you're not. It's your hair cycle. You have all these follicles that are in the energy storage to determine if they throw the hair. So they throw the hair off. And so, and as the follicles go back, you get closer. Yeah, cancer drugs will essentially take the follicles and just dump them into the and keep them there. Usually when the drug is stopped, the hair will be growing. Unless you've been on the medicine for a really long time, then your hair may not grow back. Also, cancer drugs, sometimes when your hair grows back, it can be fragile at first. Some of you will care for cancer patients and you'll see them go through that. It's Hannah, did you get your scans back? Bad? So it's both ACL and PCL or just ACL? Just ACL, okay. Is your MCL okay? Oh, that's okay. They're just sprained. They'll get better. Okay. Okay. But the ACL is torn. Okay. Okay. You're going to have an autograft hamstring or patellar? Patellar. Oh, okay. Okay, folks, let's resume. All right, so rheumatoid arthritis is an autoimmune disease. An autoimmune disease. It's prevalent, as you can see, in about 0.5% of adults in the United States. It's about really similar to that in Europe. It, of course, is higher in some places than others, but 2.5 more times common in women than in men. The guidelines for treating rheumatoid arthritis were updated recently. That paper is free, so the website is there if you're interested in taking a look at the guidelines. I used a lot of these guidelines in preparing this, so you can read for yourself if you want. Your goal is to minimize disease activity so that people have less pain, better quality of life, prevent irreversible joint damage. When the joint is eroded away, it's not going to grow back. You want to preserve joints as best you can and help people have quality of life so they can move, they can do things they like to do, so on and so forth. So the new guidelines say you go straight to a disease-modifying anti-rheumatoid drug. You don't mess around with steroids or NSAIDs first. You go straight to a DMARD. And first line is going to be methotrexate in most cases. The DMARDs, when you get on them, they don't start working right away. You can use drugs to bridge people while the DMARD is kicking in. You can use low dose steroids. You can use NSAIDs. Those drugs are meant to be used short term because of their side effect profile. And once the DMARD kicks in, you get them off the steroids as fast as you can, and the NSAIDs as fast as you can, and so on and so forth. Now, if you have mild disease, many rheumatologists will prefer that you start with either hydroxychloroquine or the sulfasalazine. If, however, you have moderate to high disease activity, methotrexate is usually your drug of choice. Now, as the ATI video or module really nicely pointed out, the dose for anti-rheumatoid arthritis activity is much lower than is used for leukemia. Therefore, methotrexate at the dosages at which it's used for rheumatoid arthritis is usually well tolerated. The big side effect profile that you get with leukemia, that can happen, but it doesn't happen very often, at least if you're using it for rheumatoid arthritis. But it's still going to be your job to look for the stomatitis and the stomach ulcers and the, bone marrow suppression and whatever else. So there's lots of data on methotrexate, lots of data. It limits joint damage, improves clinical outcomes. It works. It works. But it usually doesn't kick in earliest till 6 weeks. And in some people, it can take several months to get to full steam. You guys remember from the ATI module how it works? How's it work? Sorry? Okay. Who has? Anybody? Bueller? Okay, Reader's Digest version. When you synthesize DNA, the synthesis of nucleotides requires the transfer of single carbon units. The cofactor involved with transfer of single carbon units is called tetrahydrofolate. The tetrahydrofolate can carry single carbon units, and in the synthesis, particularly of purines, and in the synthesis of thymine from uracil, tetrahydrofolate plays a major role. Now, tetrahydrofolate is synthesized from folic acid, and it's converted to tetrahydrofolate by an enzyme called dihydrofolate reductase. Methotrexate binds to dihydrofolate reductase and inhibits it. Because it inhibits it, you can't make DNA. You can't make this cofactor that's essential in the synthesis of purines and pyrimidines, and therefore you can't make nucleic acids. So cells that need to divide in order to do what they do, like immune cells that are attacking your joints in these cases, will stop attacking your joints. They get hamstrung. So that's how this drug works. And that's why it takes a while for this drug to work, because the cells get inhibited bit by bit by bit by bit. Most of the side effects you get with methotrexate. So can be mitigated by supplementing with folic acid. There are lots of good folic acid supplements that are out there. You can get them at Weatherwax, you can get them at Meijer, you get them at Walmart. If they can't really digest it, then there's sublingual forms. Heck, there's even injected forms you can get. If you want to inject it, there's lots of different ways to supplement your folate. So folate supplementation can really save your patient's bacon when it comes to side effects if they're on methotrexate. Big issue comes if this stuff starts to accumulate in the body. So it's not recommended in people with severe renal impairment for that reason. It's going to accumulate. It's going to cause a lot of problems. You don't use it in people who are alcoholics or in those with pre-existing liver disease. Even in those who use it, you monitor liver function levels. And see the big arrow there on the bold? Please recite this with me as I read it. Patients should be screened for active hepatitis B and C infection before methotrexate is started. That's a must do. And it's going to be your job as a nurse to do that. That's a must, 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 must. So put a star by it, pay attention to this, please don't forget this, please put a, whatever. When I was in choir, when I was in college, if the director wanted us to watch, he told us to draw a little pair of eyeglasses at the place where it was supposed to watch. I said, that's really dumb. He said, just try it. So I did it and it actually worked. When I saw that, I was like, oh, I need to watch. So look up for my music and watch it. So in low doses, pretty well tolerated. It can cause irritation of the stomach, loss of appetite because the stomach is irritated, nausea, vomiting, abdominal cramps. You're not going to want to eat if you have that. Fatigue, and then some evidence of liver damage due to these liver enzymes going up, and then liver damage in the form of hepatic fibrosis. At these low doses, that's not common. But if you check those LFTs, that essentially will tell you if this is happening. If it is, you stop the drug and liver should go back to normal. Yeah, okay. It's also used for leukemia, yes. Yeah. Yeah. In leukemia, if one of the things it's used for in leukemia is methotrexate is given intrathecally to prevent the leukemia from spreading to the central nervous system. That's one of the places where it's used. It's also fairly effective against certain types of leukemias in combination with other medicines. So because it's an antifolate drug, monitor complete blood counts routinely, and then supplement with folic acid or folinic acid during treatment. That is your job. Pull that blood, do the CBCs, tell them, are you taking a folate supplement, taking it consistently, how much you're taking, so on and so forth. Now, myelosuppression is rare if they're taking the drug as prescribed. Can it happen? Sure, it can happen. So your CBCs are going to tell you if you're having myelosuppression. That's why watching the CBCs is so important. Now, on your blood draw, you may see odd white cells. You can send them to a hematologist. They may have kind of a lymphoma-like condition that goes away once they get off the drug. So while this is potentially worrying, it's usually not something to worry about. Most rheumatologists won't worry about that. The other issue is interstitial pneumonitis. That doesn't occur very often. If it does, it can be severe. And then some people will experience pulmonary fibrosis. So if that happens, the drug needs to be pulled. Any other drug that's going to mess with folate metabolism will interact adversely with methotrexate. So your sulfa drugs cannot be used if someone's on methotrexate. Using this with anything else that can damage the liver will damage the liver. So the patient should not drink when they're on methotrexate. There was a paper that looked at how much people can drink if they're on low dose methotrexate. And the conclusion was the occasional beer, the occasional glass of wine with dinner or something like that is not going to cause liver damage. Long-term studies showed that even people who drank a little had more liver damage than those who didn't drink at all if they were on methotrexate. So if someone is going to drink, what's your job as the nurse? Let them know, educate them. You educate them. Part of being an adult is managing your own risks, right? To manage your risks, you need, starts with an I, information. You are the repository of information for the patient. You need to teach the patient, so teach them. Because the physician won't teach them, then another patient goes say, you're going to teach them. So help them manage their own risk. They want to drink when they're on it, they want to manage the risk, that's their life. Can you make that decision for them? No. But you can educate them on what the risks are. And then they manage their life as best they can. Questions about methotrexate. If you have more questions, take a look at the ATI module. It's really quite good. Hydroxychloroquine. Despite what people in my Sunday school class say, it is not an effective treatment for COVID-19. This has been tested in large, double-blinded, placebo-based studies, and it has failed. It failed as an early treatment. It failed as a later treatment. So it is not a treatment for COVID-19. Well, they use it in Africa. Yes, they use witch doctors in Africa too. So what? Oh, they got better on a witch doctor. Told you. So no, but it is a drug for malaria, and it is a drug that is used for rheumatoid arthritis. It's typically well tolerated at these doses. You can use it with methotrexate. You can use it with sulfasalazine. It's usually used if people have mild disease. If they're on hydroxychloroquine and the disease gets worse, instead of switching someone to methotrexate, usually methotrexate is layered on top of it. Typically not. Typically not. If someone has a healthy liver in the first place, typically not. If someone has glucose 6-phosphate dehydrogenase deficiency, you will see that in people descended from families that lived in places where malaria was endemic, like the Mediterranean, like West Africa, places like that. This is going to increase hemolysis. So it's contraindicated in people with glucose 6-phosphate dehydrogenase deficiency. There's very good genetic tests for that. Other things will cause them trouble too. Sulfa drugs, fava-beans, certain plant alkaloids. That will be the tip-off essentially that they might have an issue. It can cause retinopathy, but the risk of that is low at the dosages at which it's used. Nevertheless, people on hydroxychloroquine should have an eye exam every year to make sure that their retina is not going south. It can prolong the QT interval. You prolong the QT interval, that can devolve into torsade de pointes. Torsade de pointes is potentially lethal. So this just shows you the elongation of the QT interval, essentially. So don't combine this with other drugs that elongate the QT interval. You'll make it worse. You increase the risk of torsade de pointes and cardiac death. That's the big drug-drug interaction. Don't combine it with other things that increase the QT interval. The over-the-counter ulcer medicine, cimetidine, will inhibit enzymes that metabolize hydroxychloroquine. So those two don't like each other. Don't use those two together. And if you use it with tamoxifen, you increase the risk of the retinopathy. So don't use it with tamoxifen or other SERMs for that matter. Sulfasalazine is a prodrug. You have two different moieties, sulfapyridine and 5-aminomesylamine, that are linked together by an azo bond. Your GI tract cannot hydrolyze azo bonds, but the bacteria in your colon can. So they hydrolyze it and then it's absorbed. And you have two powerful anti-inflammatories now that have been absorbed in the colon. It can take a while for this to work, as you see there. You can also use it in combination with these other DMARDs that we talked about. So it plays nicely with those drugs. This drug can upset your stomach, but there's an enteric-coated delayed release formulation that seems to allay that particular side effect. Serious adverse reactions are rare, but they can happen. So they will include things like inflammation of the liver, hepatitis, low white counts, and then agranulocytes that counts really go up. So you're going to do a complete blood count and liver test. You do them before you start the drug, you get a baseline, and then for the first 3 months, you do them every 2 weeks. Patient comes in, you draw it, send it to the lab. You should get those results very quickly. Also contraindicated in people with glucose-6-phosphate dehydrogenase deficiency. With this drug too, in guys, sperm counts will tend to dip. Once the drug is withdrawn, they go back up. So if you're trying to start a family, that can be an issue. If you're using the enteric-coated version of this drug, don't take it with antacid. That will cause premature dissolution of the enteric-coated formulation, and you'll get the GI side effects. That particular formulation was meant to avoid. You might also get that if you use it with the histamine 2 receptor antagonists like Tagamet and Rheumatoid and cimetidine and drugs like that. Sulfasalazine will decrease the absorption of digoxin. That's a drug that's used for heart failure. We'll talk about that when we get to the CV drugs, cardiovascular drugs. The flunomide is an inhibitor of pyrimidine biosynthesis. Pyrimidine biosynthesis only has a few steps. One of the intermediates that you make is a molecule called dihydroorotate. And then there's an enzyme called dihydroorotate dehydrogenase that converts it to orotate. This drug, leflunomide, inhibits that enzyme. So you don't make pyrimidines. You don't make pyrimidines, you don't make DNA, nor do you make RNA. Now, this drug does not play nicely with methotrexate. You can't use these two drugs together. They don't like each other. So this is an alternative to methotrexate. It works in people with rheumatoid arthritis. This drug upsets the GI tract. Diarrhea is really common, and some people can get bad. You also get hair loss, that's reversible. Rash, hypertension, so make sure you watch blood pressure. Bone marrow issues, and then hepatotoxicity are not frequent, but they're not rare. Rare side effects include allergies to the medicine, Stevens-Johnson syndrome, peripheral neuropathy, pins and needles, fingers and toes, vasculitis, interstitial lung disease, so on and so forth. So this drug probably has the worst side effect profile out of the main traditional DMARDs. Now, this bit that's underlined, pay attention to this, please, because this is important. If someone is pulled off leflunomide, you have to use these bile resin acid binding drugs that will bind the drug and get it out of your system. If you don't, it remains detectable in your blood for up to 2 years. So the drug of choice that's used is cholestyramine. Cholestyramine is very cheap. You have to take it with a lot of water. If you don't, it'll plug you up something fierce. And it binds up your bile acids, and then it binds things soluble in the bile acids, and it goes out the chute, essentially. So you must do that if someone is being pulled, if the flutamide is being pulled. You must do this. Very important. If not, they're going to take other drugs and they're going to interact with the medicine that's still in their system. So they can't just stop taking this medicine. That's the other thing. They have to take it consistently. And if they don't want to be on it anymore, you have to do this step here. Okay, that's the education part that you're going to have to impart. That's really important. This drug also has a bag full of interactions. So it's metabolized by multiple cytochrome P450s. So if you have inducers of these particular enzymes, so rifampin, for example, is a C34A inducer. Phenytoin is a 2C19 inducer. Flutamide will decrease the anticoagulant effect of warfarin. So bleeding now becomes an issue. Most hematologists would say, don't put those drugs together. They don't play well together. If you use it with oral contraceptives, you'll increase the concentrations of the particular estrogens, and that'll increase potential side effects, one of which is blood clots. And it can increase serum concentrations of other drugs, and you reduce your rosuvastatin. If you're on rosuvastatin, the statin, you have to reduce it. If you use it with methotrexate, it kills your liver. So you don't use those two drugs together. Never, 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 never. Any questions about the traditional DMARDs? A lot of nursing responsibilities with those drugs. Okay, biologics. And then the so-called Janus kinase inhibitors, JAK inhibitors. Biologics are antibodies. They will typically be injected subcutaneously. So they will usually come in injector pens. Oh, I forgot to say, methotrexate comes in an injectable form as well. Comes in injectable and a sub-Q form if swallowing pills is an issue. The biologics are brought in if they fail with the traditional DMARDs. Biologics are expensive, really expensive. So insurance will usually not pay for them unless you failed with the traditional DMARDs or you just don't tolerate the traditional DMARDs. The new guidelines say you should try to do combination therapies with the traditional DMARDs before you go to the biologics, because those can work as well or better than the biologics. All right, biologics. These are reserved for treatments that don't respond adequately to methotrexate or the traditional DMARDs. There are several of these. So the first of these is the tumor necrosis factor alpha inhibitors. These are antibodies against tumor necrosis factor alpha. They prevent it from binding its receptor. There are 5 of these, as you can see. Notice they all end in MAB, meaning monoclonal antibody. There is adalimumab, that is Humira. There's tocilizumab, and it's called PEGAL because it's a pegylated antibody. And tocilizumab, that will be important. This is the one called Cimzia. That's tocilizumab. Etanercept. Etanercept is probably the oldest of these drugs. That's the one that goes by the name of Enbrel. You'll see commercials on ESPN for that one, Enbrel. Golimumab, that is Symphony. And then infliximab, that's the one that's known. Well, infliximab now is in several bioidenticals that are cheaper. So it goes by several. The original name was Remicade. It was called Remicade. Now there's bioidenticals called Absola, Inflecta, and Renflexis. I'll write these down just so you can recognize them if you hear them. So the old name is Remicade. Then there's Absola, Inflectra, and then Renflexis. These bioidenticals are anywhere from $1,000 to $2,000 cheaper than the original Remicade. That's why the companies made them, to compete. And it's driving the price down. The price is probably going to get lower than what's listed here. If someone doesn't get good relief with one tumor necrosis factor inhibitor, they can switch to another one. And they may get relief with that one. So you can combine them also with methotrexate. That gives an additional benefit. These drugs have a faster onset than the traditional DMARDs. Many patients will report after the first injection, they'll start feeling effects right away after the first injection. There aren't any really head-to-head trials comparing them. They seem to be similar in efficacy and similar in tolerability. Now, etanercept has a short half-life that makes its toxicity really unlikely. These two, golimumab and infliximab, they're approved for use for rheumatoid arthritis in combination with methotrexate. So usually those aren't used as monotherapies. They're used with methotrexate. Adalimumab, Humira, on the other hand, is used as a monotherapy. On the average, these drugs are pretty well tolerated. The biggie is injection site reactions. So fever usually occurs after the first few injections. That tends to go away. Some people will get kind of hives or shortness of breath. That can occur. Usually it's more the itching, the hemorrhage, so on and so forth. Again, it's a sub-Q injection. Make sure they're rotating sites and teach them how to properly inject. Cytopenias, low blood counts have occurred, but they're rare, really rare. So you've seen reactivation of hepatitis B with these drugs. The biggie is tuberculosis. So you must do a tuberculin skin test after starting treatment and periodically thereafter. The gamma interferon release assay, that's for someone whose skin test is already positive. They had a previous bout with tuberculosis. So the skin test is not going to be that informative. Now the interferon gamma release assay is going to be much more informative. The skin test is easier. So the TNF inhibitors increase the risk of these other diseases. You must watch them for these other diseases. You must teach the patient the signs of these other diseases. If they have an issue, they need to come get treatment right away. Because the infection is not going to be subacute, subclinical, it's going to be bad. It can kill them. So you need to emphasize, you need to, if you get any inkling you've got a disease like this, you need to come to the hospital right away. Increased malignancies have been seen, but is that because of the medication or is that because of the rheumatoid arthritis? Not clear, because rheumatoid arthritis itself is a risk factor for lymphoma. So why you have increased lymphoma, is it causative? Not been shown. Not been shown. You might get some sort of autoinflammatory thing that happens rarely. The biggie here is the one that's underlined. If someone has a demyelinating condition, they can't use TNF inhibitors. TNF inhibitors will make it worse. So if someone has CMT, Charcot-Marie-Tooth syndrome, either type 1, 2, or 3, or 1A or 1B, or 3, 2, 3, 4, whatever, or multiple sclerosis, they can't use TNF inhibitors. They're also contraindicated in people with class 3 or 4 heart failure. Questions about the TNF inhibitors? So 4-week supply of Humira, it's taken once every 2 weeks. So this would be a month supply. A month supply of Humira is $6 grand. Certolizumab is taken maintenance. You take it once every 2 weeks. Month supply is $5 grand. Etanercept, that's taken either twice a week or once a week. 30-day supply of that drug is $6 grand. Golimumab, Simponi, 2-month supply of golimumab. You take it once every 8 weeks, it's $6 grand. Drugs are not cheap. They're usually fully covered, but the insurance company needs to know that you failed with the traditional DMARDs. You have to demonstrate, you have to have the medical records, they have to be sent to the insurance company, so the insurance company knows, okay, cool. You, or maybe your rheumatologist tries you on this, you get much better relief with the TNF inhibitor than you do with traditional DMARDs, and rheumatologist said she needs to be on Humira or she needs to be on, whatever, then they'll begrudgingly pay for it. So it's usually covered with most plans. Also covered by Medicaid, Medicare. I don't know if it's complete. Plan B, partially covered. If you have a supplemental, that'll usually cover it. Medicaid, I just don't know with Medicaid. Anybody here working at doctor's office? Yeah, Maddie? Yeah, they're covered usually. Yeah, they're covered. Yeah, because the FDA has only approved the ones that have been approved with methotrexate. They have to use with methotrexate. They're not approved for monotherapy. Now, another interleukin that plays an important role in rheumatoid arthritis is interleukin 6. Remember, that's one of the acute phase interleukins. Interleukin 1, interleukin 6, and interleukin 12 are your acute phase. This one is quite important at recruiting cells that will make the pannus that eventually causes erosion of the articular cartilage. So there are two drugs that are drugs that target the interleukin 6 receptor. The interleukin 6 receptor. Those are saralimumab and tocilizumab. Saralimumab and tocilizumab. This drug can be given with or without methotrexate. And in head-to-heads with adalimumab, it seems to be more effective than adalimumab. So tocilizumab, this is a drug that is used for late COVID-19. This drug has efficacy against late COVID-19 that becomes more of an autoimmune condition. It's also used for rheumatoid arthritis. You see clinical improvement relatively early with this drug. It seems to be more effective than adalimumab. You can use it as a monotherapy. You can use it with methotrexate. Doesn't seem to make much difference. So when this is used, it's usually used as a monotherapy. There aren't any heads-to-heads comparing tocilizumab with saralimumab. Saralimumab is a newer drug compared to tocilizumab. So this drug will cause injection site reactions, also injected sub-Q. Tocilizumab is usually injected either once a month or once every 2 weeks. Saralimumab is injected once every 2 weeks. It can cause hypertension and low neutrophil counts. You can have evidence of liver damage. You can have also high levels of blood lipids. So you're going to monitor your liver enzymes, monitor lipid levels. You're going to order lipid panels and then CBCs as well. Anaphylaxis has been reported. It is not at all common. It's rare. Also rare, that it's been reported, are GI perforations. Tends to occur in people with diverticulitis. Rare, but it's been reported. Rituximab is a drug that's typically used for leukemia. So this binds to a specific B cell antigen, and it essentially depletes B cells. This drug for rheumatoid arthritis is the big gun. Nothing else works. This is a drug you call upon. It's approved only in combination with methotrexate. And it's used if they failed everything else, pretty much. So rituximab can cause the progressive multifocal leukoencephalopathy. That was a side effect with some of the drugs that we talked about for multiple sclerosis, PML. That can happen with rituximab as well. And these things down here, severe mucocutaneous reactions, reactivation of Hep B, so on and so forth. Those are some of the fatal reactions that can occur 24 hours after you take a rituximab infusion. This is not given SC, this is given by infusion. You have to go into the doctor's office to get this. And this drug is mercilessly expensive. So you take 1,000 mg dose, 2,000 mg doses, 2 weeks apart. The cost of just that 1 month treatment is almost $19,000. It's really expensive medicine. There are 3 biosimilars that have been made. They're 14,000. So they're worth $4,000, $5,000 cheaper. They're still pretty expensive. This drug is not a monoclonal antibody. It is a recombinant protein. It interferes with activation of T cells. And again, this is used typically when everything else has failed. So it seems to be about as good as adalimumab. You can use it with traditional DMARDs if you want. It's been essentially pulled out when other things don't work. This drug essentially will work. This drug is a lot cheaper than rituximab. A headache and dizziness are the biggies with this one. This one also, abatacept has to be given IV. You can't give it SC. You have to come in and get the infusion. It can pretty seriously increase your risk of infection because your T cells essentially are just shut down. So this one and rituximab are kind of, excuse the expression, scorched earth strategies. All right, this is a good place to stop. The Janus kinase inhibitors have a lot of side effects. We'll talk about those on Wednesday. You guys were remarkably quiet this evening. I'm not sure why, but hopefully you'll write me some good questions on Facebook site, okay? Okay, Erica, that's all for tonight. I hope you feel better soon.
Thank you.